And good morning and welcome to the Pulse of Healthcare. It's Dr. John McCormick. I'm sitting here with Peter, and today we're going to talk about networks. But in order to really talk about why we have networks today and why that's kind of in the American psyche of something that's quote unquote you needed or what have you, we really need to jump in the Wayback Machine and have a little history lesson up front. So I'm going to take you all the way back to the Great Depression in the 1920s. And weirdly enough, this story starts right here in Dallas, Texas with Baylor University, right? So back in the 1920s, during the Depression, Baylor University ended up with a significant revenue drop, which was actually endangering the university hospital. They could have gone out of business. All right. What they were seeing, and there's going to be some pretty crazy high numbers here, so brace yourself. Their average payment for somebody in the hospital was $236. All right. All right. What they saw during the Great Depression is that reimbursement rate had dropped down to like $59. Well, that was killing them, right? Well, they had a pretty forward-thinking administrator at the time by the name of Justin Kimball, who realized a great deal of their population that they were serving were actually teachers. Wow, imagine that, right? And so what he did was come up with the first capitation model. And what Baylor did was create a hospital-based plan that for the huge cost of 50 cents a month, $7 in today money, which we know doesn't translate anywhere close to what they charge, all right, you could actually get hospital coverage for up to 21 days. So anything that occurred in the hospital was covered. It was covered under this payment, and it was basically just a little hospital-based plan that they offered primarily to teachers in and around the hospital. Well, what it did was help balance the budget and actually save the hospital and carry them through the Great Depression. Pretty cool. All right, so here we are in about 1923 when he comes up with that idea. And by 1932, took a little while to catch on, 26 other hospitals were doing this, mainly in California. So what we saw was something that kind of incubated over here at Baylor in Texas, but then really caught on kind of in a major way in the hospital systems in California. And so they mirrored the plan that Baylor had created and then spread it out over 26 different hospital systems. So that's kind of what insurance looked like before we had all of these insurance plans and everything else. You went to see your primary care doctor, you paid cash. If you needed to see the few specialists that were, you paid cash. But what people didn't have is enough money to go to a hospital. So this was a hospital-based, hospital-only type of plan that you could buy, right? And so it gets even kind of more convoluted when you understand that in 1933, the American Hospital Association effectively endorsed this plan and at the same time limited it. They basically said, you can only do this hospital if you're a nonprofit. You can only do this if it's regionally exclusive, right? And of course, it can only cover hospital costs. So this is the medical profession basically saying, don't cross the lanes. Let primary care do their stuff. Let specialty care do their stuff. And hospitals, you do your stuff, right? And the big expense was, of course, over here, right? Which makes perfect sense, and why you might need a quote-unquote insurance product of some kind. Well, being capitalist, these things kind of catch on. And so you're seeing to see is an evolution. So you've got the American Hospital Association. Well, they basically get in bed with what becomes Blue Cross. So in 1939, the American Hospital Association and National Association becomes the National Association of Blue Cross by 1948. So there's this evolution between 1939 and 1948 where Blue Cross, which basically just started out as a hospital only administrator of this, capitation plan, to a much bigger Leviathan, still only in the hospital space, doing this. So that all kind of makes sense. You start to think about it, you're like, okay, now we've got insurance for hospitals. How did we go from that to what we're at today, right? Where you've got huge networks and it's all controlled. Dun, dun, dun. 1965, here comes Medicare. Now, back in 1925, when they started Social Security, is when this first push for national health care was actually made, right? Under Roosevelt, but under Johnson is when we got Medicare. And the reason it happened that way is exactly why I just explained, because the medical society had carved up the business into three very particular lanes. And so Congress and local politicians were very hands off. Like, we can do this over with the hospitals. That makes sense. They're expensive, monetarily. But we're not messing with these other ones, and we're certainly not wrapping them all together. So there was a lot of, medical association pushback on that kind of stuff. And it really, if you wonder, now you understand why there's Medicare Part A, Part B, Part C, and Part D. That's because they made 4 deals. All right. It didn't just all come at one time, right? It's like, they got the camel's nose under the tent with the hospitals, and then they grabbed the primary care, then they grabbed the next piece, and then they added pharmacy, and then you ended up with the Medicare Part A, Part B, Part B, Part C, Part D. Kind of crazy, huh?
Yeah, it's an amazing evolution. I was totally unaware of how that all developed through into all the different types of plans with product-sponsored and accountable sponsored programs.
Money and politics, all right, not medicine, is what drove the system we have today. Money and politics. So in 1965, when they started Medicare, right, and then a year later tied Medicare to Social Security, ding, 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 guaranteed payments, right?
Right.
You've now created a system, and what happened between that time and really about 1974 is you had these insurers, Blue Cross being the major insurer in the country, where prices were just running wild, right? They haven't set up the base cost for Medicare. There was a lot of actuarial stuff going on to determine what reasonable and customary rates were. There was no standard, not only between hospital and hospital, but state to state. I'd like to say it was better now, but it's not. Just as bad. It's just as bad now, maybe worse now than it ever has been, even with all the laws we have to supposed to make that very transparent. And so what you ended up with was the rise of the network primarily under the HMO model, all right? And the HMO model was designed to take a particular set of doctors with a particular set of hospitals and a particular set of specialists and drive mainly employer groups into these narrower networks where they could manage their care and control the cost. Dun, dun, dun. So what we think has existed our whole life, or going back, because people don't know. They don't know when it started, right? It's like, this is the way it's always been. Well, no, it's not. And it's certainly not the best way unless you're on Wall Street, and it's amazing because you're making billions of dollars a year. But it's certainly not the best way that care can be delivered or the best for the patient, right? So we think about the huge companies today, but you know, these companies outside of Blue Cross, because I am not that old, all right, they all came into existence in my lifetime. So United didn't start until 1974. Cigna not till 1982, right? Aetna, although was a life insurance company that went back to the 1800s, didn't get into the healthcare business until 2011. They're babies. They're huge, but they're huge babies. All right? And then, of course, there's dozens of other ones now, right?
Right.
Including the Kaiser Network and so many of these other ones. But they all spawned from that genesis of Blue Cross back in the 1930s, and then, you know, kind of hate to say metastasized, but they really did, kind of like a cancer, started growing after Medicare got passed. That's what happened, right? So now we have this philosophy that we're starting to drill into the minds of the American population that says you must have a network to get care. You know, and then now we start to parse out the doctors. You're in network, you're not in network, this hospital's in network, this hospital's out of network. But all that really has to do with, it has zero to do with care, it all has to do with contracts. Which plan could contract with whom, right?
Right.
And as we know, you can get care anywhere for cash, right?
Right.
And you can certainly get care anywhere if you have a plan like Ovation that's willing to reach out to these facilities and negotiate those rates on your behalf. So a contract actually can be a bad thing in that contracts, just because you have a contract doesn't necessarily mean it's good, right? Matter of
Right.
fact, it could be horrible.
Right.
and they often are. So networks is a really a marketing ploy and a control mechanism that were brought into being in the 1970s that were drilled into our collective conscious as something you must have, and then reinforced by the state boards of insurance, that you know the departments of insurance that are supposed to regulate insurance to make sure that you're getting all the care you need. Well, in order to be a qualified plan in a state, you have to say, here's my network. So
Interesting.
right. So you have to show them you have a network, because the fake concern is that if you don't have a network, then somebody might not get some kind of care that they need. And so there's some arbitrary litmus test that the Department of Insurance is putting these plans through to say you have so many primary care, you have all the specialists in all of these areas, and you have hospitals that you have agreements with, and therefore you have a qualified network. They didn't say it's a good network. It could be an awful network. They don't judge your contracts. They could be awful contracts, right? But what they've done is kind of reinforce this misnomer that if you don't have a network, then you won't get care. Well, we know, since we've been in this business since 2015, I mean, shortly after Aetna, I mean, you don't need a network. What you need is people that understand the system, and physicians and specialists and hospitals that are really willing to work with you, with your plan, with your employers, that have the same mindset of Baylor back in the 1920s, that we need to be able to serve our local community at a fair price.
You know, Dr. John, in looking at networks and in-network, out-of-network, the way they sell it is primarily on cost savings if you stay in network. They'll mention coordinated care, they'll go access to services. All of those things don't have to be in network, do they?
Well, so here we go again. So, you know, ironically, this is where the federal government and the states got in a big fight right at the end of the Trump administration, right? So the Trump administration passed a law that basically superseded state laws. So that goes back to 1945 when I think it's the Haley something other act. There was an act that was passed that basically said that the states could regulate their own insurance, that it wasn't interstate commerce. All right, and then they passed after they passed the No Surprise Act, they went, well, kind of is interstate commerce because a lot of people are crossing borders and getting different care in different areas, and some regulations need to protect everybody regardless of what state they're in, right? So the Fed came back and made a new argument and said, hey, here's the new law, and we're going to regulate this, extensively under the No Surprise Act, and other regulations to try to manage this in-network, out-of-network scenario. Because what was happening is I would go to the quote-unquote in-network hospital for my plan, right? Mm-hmm. And then the specialist in that hospital that would come see me was not in my plan's network, even though he was on staff at the hospital. The anesthesiologists are notorious for not being in anybody's network. So what you ended up with all these weird little subspecialties that were not in network with your plan, even though they were the ones contracted with the hospital to provide you care. So you ended up with these bills like, but my insurance company paid the bill for my procedure, and yet I have bills from this specialist, this anesthesiology group, this radiology group, and they were denied by my insurance because they were, quote unquote, out of network. All right, and now me as the consumer, is allegedly on the hook to pay those. Right? To me, that's bad business. I mean, that would be like, we're going to sell you this car, but if you want to get the seats or the gear shift or the engine, that doesn't really come with the car. Some assembly's required, and you got to pay extra for that, right? So I will take out your appendix, but if you want to be, anesthetized while we do that, you're going to have to sign another check. Like, what? Did I have a choice? I mean, it's like you asked me, do you want that with or without, going into the deal. So that's the kind of it's a weird kind of deal, but you got to understand the genesis of it was about control. And they've done a phenomenal job, not only about controlling the American psyche, that it's something that you need, but also about the insurance companies controlling their cost, right? The best way around that is reference-based pricing, bundled service pricing that includes everything, right?
Yeah.
Kind of things that we do and some of the other plans that are on the cutting edge of this do. Those are the kind of things that actually save money, eliminate this in-network, out-of-network nonsense, all right, and get people the kind of care that they need.
As one who has gone through the experience of in-network, out-of-network, and all of these specialty prices coming into, you just can't understand the whole thing. It's such a big package of bills. I mean, I got a inch-thick bill.
Right.
Of doctors I had never even seen, and let alone known that they were even there.
They didn't even know they were in the room.
Yeah.
They walked in, tag in, $300. Thank you. Have a nice day. Out of network. Oh, by the way, Peter, you get to pay for this because he poked his head in and looked at your chart. Maybe. I don't know. I was unconscious at the time. I can't swear he saw me or not. I don't remember talking to him.
Yep.
Those are the kind of things that we suffer from. So let me kind of wrap this up. Networks are in the American psyche. It took decades to get them into the psyche. Obviously, the history goes back a long way. They're part of the perversion of the system, all right, that's really kind of, hate to say, designed to keep the big movers and shakers and money makers and Wall Street guys and lobbyists employed and well paid. It has nothing to do with, delivering high quality health care at great prices for small and medium and large employer groups. In order to do that, we really have to band together, break the system, I hate to say it, and focus on delivering high quality care with physicians and specialists and hospital facilities that are willing to work directly with the consumers.
And that's exactly what we do here.
Right. Thank you very much. We'll be back in a couple of weeks with another episode of the Pulse of Healthcare.